All right, thank you. So my name is Franklin Valdera. I'm a resident at Brooke Army Medical Center. Myself and my team will be presenting today on multiplex microsphere-based immunoassays and their performance in assessing COVID-19 seroprevalence in a deployed military field hospital setting. We don't have any disclaimers to present, and we'd like to thank our grant funding for laboratory testing for this study. So this study takes place about 2 years ago now, in April 2020, when the pandemic was a bit more stressful on the United States and really worldwide. There was a relative scarcity at this time relative to now in factors such as PPE for those presenting direct care to patients. And there was, more importantly, also scarcity of widespread availability of rapid diagnostic testing at this time in the pandemic. And so with these factors in mind, medical facilities throughout the United States and the world had a real burden with patients. And in that light, 3 medical brigades were deployed to New York to aid with this patient burden. And they came from the 9th and 531st Hospital Centers, as well as the 44th Medical Brigade, so Fort Campbell, Fort Hood, and Fort Bragg. And they formed the Javits Medical Station in New York. And so Javits was an open-air convention center where patients who were overflowing from these hospitals in New York were able to be treated and cared for. All of these patients had a severe infection burden. They were all on oxygen, so they were sick. And those who were transferred to Javits were, can you go back, please? In one of two categories. So they were either sent from the ER to Javits after presenting, or they were seen in an inpatient setting, stabilized, improving, still severe, and then sent to Javits prior to being sent to a secondary care facility. Strict infections control measures were taken at Javits to ensure that those providing this care to these patients weren't themselves infected with the virus. And this was involving, the standard donning and doffing with intermittent sanitization, and even walking through bleach pools to sanitize boots. It was very strict. In addition to patient care, multiple research projects were conducted at the facility. At this time, and relevant for this study, the FDA had granted emergency use authorization to IgG ELISA testing for COVID-19. And this was unique because it was in the setting of really no availability of specificity or sensitivity data for this test in the COVID-19 virus. So there were many concerns raised about how good it was relative to the current gold standard at the time, which was PCR. There were also concerns that there may be cross-reactivity causing false positives in other coronavirus variants. There was a cost factor, time, and also single antigens can only be assessed at once. At the same light, multiplex microsphere-based immunoassays were being developed, which is another serologic test, but the difference stems in the fact that this can test multiple antigens and pathogens at once, whereas ELISA only tests as one. Also, you can test very small assay samples, as small as at the time of this study, 2 microliters. And it works quickly to identify both the virus itself as well as variants. So you negate false positivities from those, and then you can also detect other pathogens. So the primary outcome of this study at Javits in the setting of these 2 test measures was looking at the sensitivity and specificity of MMIA versus the FDA EUA gold standard ELISA test. And so all patients that were treated at Javits were offered the ability to enroll. There were 76 of them total at the time of the study. 46.1% were eligible and underwent all forms of testing, so that included MMIA test, ELISA testing, and the PCR, which was the gold standard. Interestingly, soldiers providing care to these patients at Javits were also eligible to test, and this was to test whether or not healthcare workers had an increased risk of contracting the virus from providing care. This is interesting because Javits was an open-air convention center. There were no negative pressure rooms. It was hard to have the same standards that facilities have in a hospital setting. So ultimately, 56.8% of soldiers were eligible, all of which completed MMIA and ELISA testing, 6 of which did not complete PCR test. And for results, so in the patient setting in the table to the right, we'd see that the ELISA IgG was positive for all 35 patients who were enrolled, demonstrating infection. And for MMIA IgG, it was concordant with all 35 patients having a positive result. Interestingly, in the soldier population, 5 soldiers had a positive test ELISA-wise. Only 2 had one positive on MMIA. The 3 who did not have a positive test had the lowest possible positive titer of 1/80 on their ELISA IgG. And so, looking at the validity of the test, MMIA versus ELISA had a sensitivity of 92.5%, had a specificity of 100%, and there was complete concordance for serum IgG titers that were greater than 1/80, which again is the lowest possible positivity rate. And that was in those 3 soldiers. And so it begs the question of whether or not it was either a false positive from the ELISA test or a false negative from the MMIA test, which we did not have the data to analyze for this study, but is being investigated. And then to conclude, the test performed well relative to the FDA gold standard. Seroprevalence from variants were low as well. I didn't show this, but variants of the coronavirus family were tested with MMIA, as aforementioned, and were not noted to have a high positivity rate, which was consistent with the high infectious precautions measures taken at Javits, showing that there wasn't a variant prevalent. Potential use for MMIA testing is something to consider, especially when you're considering surveillance efforts for COVID-19 and other variants, as well as biowarfare. Limitations included that patients were transferred later in their course to Javits. So typically patients presented at 25 days out after symptom onset, but still had an oxygen demand. But it begs the question of having a lower infectious burden and therefore less transfer to those providing care. Those who did provide care only spent about 30 days with patients before Javits was closed. And that can affect certain serology tests because some antibody titers take about 4 weeks or so to mount a response significant enough so that your sensitivity is positive. And so therefore it could be less positive in that time frame. And then recall bias is, of course, a concern with any study that utilizes an anonymous survey, which is how patients and soldiers were incorporated. These are my references, and thank you for your time.